A very good morning to one and all of you. I think what I'm going to do is over the next few minutes give a brief update of what has happened in the field of ocular surface and what is new in the field of ocular surface. It's not moving forward. Yeah. So the update will cut across disease pathophysiology, newer diagnostics, innovations, and management of ocular surface diseases, including Stevens-Johnson syndrome, OCP or MMP, dry eye, and chemical injuries. So the last couple of decades saw a lot of insight and understanding into Stevens-Johnson syndrome, and we were able to zero in on lid margin keratinization as one of the major issues that causes ocular surface deterioration in these eyes. And we were also able to understand the role of mucous membrane grafting in addressing lid margin keratinization in these eyes, which significantly reduces the blink induced microtrauma. And this has now been credited with a window of opportunity in these patients of SJS, where it can actually help stall the deterioration in the ocular surface. Also, we today understand the need for a comprehensive approach to patients with chronic ocular sequelae of SJS, which is broadly categorized under procedures that help to stabilize the ocular surface, tectonic procedures, and visual rehabilitative procedures that range from optical iridectomy to cataract extraction to the different types of keratoprosthesis. In the last 25 years, we have seen a paradigm shift in the management of patients with SJS, where several newer management modalities have helped significantly improve the outcome in these patients that otherwise used to have a significantly downhill course. The white spots, which had eluded us for quite long, are now recognized as ectopic sebaceous glands of Gibson along the lid margin, which fortunately do not have a significant role in causing any harmful effect to the ocular surface, but they can be triggered by the inflammation that occurs in Stevens-Johnson syndrome. We've also tried to understand the pathophysiology of the disease by conducting various cytokine studies in the tear film of these patients in an area where there is a significant paucity of literature, because ultimately, as we all understand, unless we do not know the pathophysiology or identify the biomarkers in these patients, targeted therapy is going to be difficult. And this was one of the hallmark publication under the lead authorship of Professor James Chodosh, where several key specialists from India were part of this particular paper, where we identified the windows of opportunity which are now considered as mandatory roles for ophthalmologists in the management of the acute as well as the chronic stage of Stevens-Johnson syndrome. Simultaneously, chemical injuries also saw a significant revolution in the management of the chronic stage in the form of simple limbal epithelial transplantation or SLET, where we moved away from the laboratory and transitioned from ex vivo limbal stem cell transplant to SLET with very good outcomes. And today we know that the decision making for both limbal as well as corneal reconstruction in these eyes has a very specific algorithmic approach that have been provided by various groups, which more or less are quite similar, whether it be bilateral limbal stem cell deficiency, where the key decision is to decide between the need for a keratoprosthesis or limbal stem cell transplant techniques, which in this situation would require systemic immunosuppression, or in unilateral limbal stem cell deficiency, where usually the algorithmic approach is quite straightforward and largely depends on limbal stem cell transplantation. What we've also realized that in these eyes with both bilateral as well as unilateral limbal stem cell deficiency, if we are able to achieve a moist surface or retain a moist surface, retain the well-formed fornices with the normal corneal thickness and clarity of the cornea, these are the eyes that have the best outcome. And in very severe grade acute chemical injuries, one of the means to achieve a good outcome by appropriate management in the acute stage has been the role of alloslet in the acute stage of chemical injury, which has significantly helped us to rehabilitate these patients subsequently in the chronic stage with a good outcome. The comparisons between alloslet and just amniotic membrane in severe grade injuries has definitely revealed a beneficial role of alloslet in these eyes, which was based upon our understanding of the pathophysiology in the acute stage of chemical injury, which primarily revolved around what we today term as the I's and E's in the management of acute chemical injury, which formed the basis for us to have proposed what we call as an enhanced grading for acute ocular chemical burns, or EPICS, which is an acronym that stands for epithelial changes, pressure, ischemia, and exposure, all of which are parameters that need to be mandatorily addressed in the acute stage of chemical injury in order to have a good outcome in these eyes. Alloslet does not have a role to play just in chemical injuries or limbal stem cell deficiency, but also in ocular surface tumors, especially the large ones that involves a diffuse aspect of the cornea, or the giant OSSNs, where these patients can end up with a limbal stem cell deficiency postoperatively, and alloslet has had a role in reducing the occurrence of LSCD as well as the risk of symblepharon that we see in these patients otherwise. An important topic in OSD, of course, is dry eye, and no talk will be complete without an update on dry eye management in these eyes. Today, we know that we have a gamut of investigations as far as dry eye disease is concerned, and all of them do have a role to play in the diagnosis of the different types of dry eye, especially the meibomian gland dysfunction and the aqueous tear deficiency. We do have recently approved new treatment options for dry eye, though artificial tear substitutes still continue to remain the mainstay of treatment in these patients. And it's important to understand that amidst the availability of all these modalities, it is important to identify the logic amidst the chaos, and there is a need for a workflow in these patients which can be a uniform platform amongst all ophthalmologists, including specialists as well as general ophthalmologists, which is what we proposed by formulating what is called as the dry eye module, an application intelligence platform for diagnosing and monitoring dry eye disease, which is available for use by all specialists as well as cornea specialists and general ophthalmologists. And this is a very brief video that shows what the module does. Can we have the video, please? Yeah, so basically it gives you a diagnostic sheet once you enter the examination findings. It also produces a cornea rheumat interface sheet, a customized letter for the rheumatologists, and it forms a very useful tool where all of us can talk the same language as far as identifying the parameters and diagnosing the dry disease is concerned. And I would like to end by talking about the field of keratoprosthesis, which forms the last resort for end stage ocular surface disorders. One of the options that we have today is the Boston type 1 keratoprosthesis. This was our first patient of Boston type 1 that we did for an oil filled eye way back in January 2008, which is when the type 1 KPRO was initiated in several institutes across the country. And this patient today has a 15-year follow-up, maintaining a vision of 636 in her only eye. And we've only learned over the journey about the nuances of keratoprosthesis in these patients, and this was one of our very early osteoodontokeratoprosthesis patient, a 10-year-old child of SJS who had been following up with us since 1995, underwent the procedure of MOKP in 2005, and today 18 years later continues to maintain a vision of 6.6 N6, which was something that was unheard of way back then. This is a panel of the different types of keratoprosthesis that is currently available, and at Shankar Nethralaya we have all the different types of keratoprosthesis as well as limbal transplant techniques that can be provided under one roof, which helps us customize and tailor the management for every individual patient. This is one article that I would like to draw your attention to, which in a very simple manner provides all the information that is required about the different types of keratoprosthesis, the indications, the techniques and the complications related to each of these. So to conclude, ocular surface disorders has been a significant area of specialty under the broad umbrella of cornea and external disease, a niche area of focus which has grown significantly by leaps and bounds in the last couple of decades. It involves the use of technology for patient care. A lot of passion and drive is required to follow this subspecialty. Definitely needs training and a huge teamwork that goes into it, and a lot of perseverance, and like I mentioned, patience as well as passion to take up this as an area of focus. We have a 3-month short-term ocular surface fellowship for anyone who might be interested after completing your cornea fellowship. And for those who might want to have a taste of what ocular surface diseases and its management entails, we have the OSCON 2023 coming up in August, the end of August, that deals with ocular surface disorders and keratoprosthesis. And I invite all of you to our upcoming Keracon in Chandigarh this year. Thank you.
Thank you, Dr. Geetha. That was a brief, excellent overview of the voluminous work that you guys are doing in your esteemed center.